Ready?
Yes.
Oh my God, I love this handout. I just made it for y'all, just so you know. Okay, so it's everything on one page. It's like so beautiful. All right, so what we're gonna do is talk about the electrolyte. What are the functions of that electrolyte? Causes of it going low, signs and symptoms of it going low, treatment for it going low, causes of it going high, signs, symptoms going high, and treatment. Got it?
Got it.
All right, so we're gonna start with sodium. What's normal sodium level?
135, 145.
Very good. What's your keyword for sodium?
Brain.
Brain. It's all going to be neuro stuff. Yes?
Yes.
All right. So y'all know the job of sodium because you watch the videos. Yes. Okay. What's its job? What's the job of sodium?
Oh, regulate your blood.
Yeah. Regulates your blood pressure because what follows salt?
Water.
Water. So it can hold in water. Not gonna, yeah.
Yes.
Aren't we made up of salt water?
Yes.
Okay. So can maintain blood pressure. It also has nervous system regulation. It helps with the firing off of the action potentials. Yeah.
Yes.
And maintains your blood volume, which is basically the same as blood pressure. Yeah.
Yes.
Okay. Actually, turn your papers over because I need y'all to really critically think on this and not read to me. Okay. So give me some causes of a patient having hyponatremia.
Diarrhea.
Diarrhea, because we've done the GI main in here before, right?
Yes.
Okay. So what's a predominant electrolyte in the gut? Not stomach, gut, sodium. So if you have a lot of diarrhea, you're going to have hyponatremia. Okay. All right. So you understand what I'm saying? If your gut is salty and you're pooping out all your gut, you've lost all your salts. You're going to get hyponatremia. So diarrhea is one of them. Okay. What endocrine condition did we talk about that caused hyponatremia? SIADH. Because what is SIADH? It's an increase of ADH. ADH just holds in water, which would water down our sodium because we're made of salt water. Yeah.
Yes.
Okay. Why would diuretics cause hyponatremia? You're peeing, you're like overriding your kidney's normal systems, right? What 3 electrolytes are your kidney responsible for getting rid of? Sodium, potassium, and chloride. So if you're giving diuretics, it's forcing those out when normally your kidney would be like, should I keep you in? Should I let you go? I don't know. You see what I mean?
Yes.
Okay. Do the easy things first. Okay. Like what would cause your sodium to go really low? Drink a ton of water, right? They actually killed somebody one time doing this. There was a radio show that was doing a game and they brought like 5 volunteers in and you had to drink an entire gallon of water as fast as you could. And the person who could hold their pee the longest won. Now, what do you think happened to that client? Well, that's probably part of it, but also you watered down their sodium. What's your keyword for sodium?
Brain.
Right. So it caused all the cells in their brain to swell. They got cerebral edema and they died. That's called water intoxication. Okay. So if you're gonna drink a lot of water, that's fine. You must pee. Yes?
Yes.
Okay. Good to know. All right. Water enemas. Okay. So I'm going to say this and it's going to sound super gross and perverted and I can't help it. Whatever goes in your butt is the same as what goes like in your mouth. It's the same exact tissue. It's the same mucus, same everything. It absorbs the same way. So whatever you put in your butt is going to absorb systemically the same way that something you put in your mouth would. Okay. Okay. So let me give you an example. There was like a couple summers ago, this is super gross and I know that, and I'm never putting this on the internet because of that. Where these teenage girls were taking tampons and soaking them in vodka and then going and like putting them up in their vaginal area or in their bottoms because it absorbs the exact same way because it's made out of the same as mucous membranes, right? So it will systemically absorb. So if you give a tap water enema, which is very common, right? Where they just put a bunch of water up your bum, right? Your body is going to absorb all that water, right? So that's basically another water intoxication. Do you understand what I mean?
Yes.
Okay. Which is why usually they'll give like a saline enema, which is probably a little bit better than just tap water enema, which sounds super gross anyway. You know how gross our tap water is? Hi, that's a parasite waiting to happen, but okay. Anyhow, all right. So signs and symptoms of hyponatremia.
Neuro changes.
All right. So all your neuro words, if you see a neuro word, you're going to pick it on an exam. Okay. Like headache, confusion, fatigue, seizures, coma, lethargy. Those are all like neuro things. Yeah. Weakness, ataxia, because your brain's all, what's ataxia? Drunk walk. Yeah. Because your brain's like, I don't know. Okay. Nausea, vomiting. Oh my God. Okay. Nausea, vomiting, anorexia. Why would you have that? Because you have nausea and vomiting.
Anorexia?
Nausea, vomiting, and anorexia. Anorexia just means I don't feel like eating. It's not a disease, right?
But don't they throw up a lot to like get filling up all of their fluid?
Like water. They're trying to kind of like get rid of that extra water, right? And then if you're like very waterlogged, you're not going to feel like eating, right? Okay. All right. How would I treat low sodium? Give them sodium. Y'all, these are very easy if you just like, okay. So if it's a very mild, what type of fluid would I give that patient? If it's a mild hyponatremia? Yeah, so we could give normal saline, right? If it is severe, if it's like in the 120s, then what kind of fluid would I give?
5%.
A hypertonic solution, which is 3% normal saline. You have to be very careful when you mess with salt, okay? Because it pulls fluid so beautifully. What happens if I give hypertonic saline very quickly? It's going to shrink all your brain cells and cause cerebral edema, and the patient could die. So anytime I'm changing sodium levels, I have to do it very slowly. So you're never going to give a bolus of a hypertonic solution that is salt. Oh, do you understand what I'm saying?
Yeah.
Now D50 will slam if they're in hypoglycemia, right? But as far as salt, you better quit it. You understand?
Yes.
Okay. All right. So let's talk about causes of hypernatremia. What would cause you to have high salt? Get very simple. You ate a lot of salt. That's simple. Yes. Okay, go on. DI was so diabetes insipidus because you're peeing out straight water, which leaves you salty. Yes. Go on.
Watery diarrhea.
Oh yeah, watery diarrhea can do that. Have you ever had diarrhea where it's like you're just peeing out your butt? Okay. Well, because it's like I have. So said your name. Anyhow, no, everybody has, you know. But if you're peeing, no, not peeing, if you're pooping out just water, that leaves you very salty. Yes?
Yes.
Okay.
So with throwing up being on our nose, is that just for
No,
hypo?
it's
Okay.
that's for more for hypo.
Okay.
And it's really more for potassium, but you will see vomiting listed in hyponatremia too. You would have to have severe vomiting
Okay.
to have hyponatremia. All right. What about if we said a water enema caused hyponatremia, then a saline enema would cause hello. So just think, what do you put in your mouth? What do you put in your butt? Those are very easy causes of either of these. Yes.
Yes.
Okay. All right. What endocrine diseases caused hypernatremia? Okay, DI. What else? It is Cushing's. It is Cushing's because Cushing's is an excess of aldosterone. What's aldosterone's job? Holding salt in water. Yes.
Yes.
Okay. And if they don't diagnose them with straight up Cushing's, there is something called hyperaldosteronism, which is basically the same thing as Cushing's, just the aldosterone part, right? All right. So signs and symptoms of high sodium.
Headache.
They're the same, right? So headache, confusion, seizures. Yeah. But you have to think about what happens when you eat a ton of salt. Like let's say you go to a party or whatever, right? You eat like pretzels and pizza and like you wake up the next morning. Yeah, your fingers are kind of like puffy. You do feel dry. You're real thirsty. Your skin's kind of flushed. Yeah, so you add those with hypernatremia. Okay. All right. How do I fix hypernatremia? Huh? No salt. So I'm going to restrict their salts and give them water. So I'm going to tell them if they're like awake and alert, drink some water. Yeah. And if they're not awake and alert, then I would give them what type of solution? A hypotonic solution. Yeah.
Yep.
That's it. That's all of sodium. Boom. Oh, see, it's easier than you think when you understand it. All right, let's go to potassium. What's a normal potassium level? 3.5 to 5. What's potassium's keyword? Heart. Okay. Because there's an action potential, right, in the heart that causes your heart to beat. Yes. It's like a, zaps you. Okay, you understand. All right. What's potassium's job? Yeah. So nerve impulses. Yes. Action potentials, especially in the heart. Okay, so if it's, then it makes your muscles contract too. All your muscles. Yeah. Controls your heartbeat.
Yes.
Okay. All right. So give me some causes of hypokalemia. Now, potassium does not act the same way as sodium does because we're not made up of potassium water, right? We're made up of salt water. So remember, potassium mostly lives where? Intracellularly, right? In the cells. Yeah. It likes to be at home. It's a home body. Okay. All right. So give me some causes of hypokalemia. Vomiting, because what's your predominant electrolyte in the stomach? Potassium. Okay, so if you're vomiting a lot, you're getting rid of your potassium. Okay. Please remember too, I don't know if I covered this on the video. Did I cover the insulin and potassium go on a seesaw too?
Yes.
Did y'all understand it? Well, because y'all said I think so, so you probably didn't. Okay.
Okay, so if they have high salt or sugar, we would give them hypotonic. If they have low, we give them hyper.
Yes. Yeah. Oh, she's like, got it. Okay. So let's say like this is one of your cells, right? Like we'll go back to this guy because y'all are familiar with this guy. Haven't I drawn this for you like 100 times?
Yes.
I kind of jacked it up. So. All right. So here are your cells. Yes.
Yes.
Okay. What's a predominant electrolyte intracellularly?
Okay.
Yeah, he liked to be at home. Okay. But promise your cells have to be closed, right? That we can't leave them open. That would be terrible. Yeah.
Right.
What opens the door to the cell?
Insulin.
Insulin. Yeah. Why does insulin open the door to the cell?
Like to come in.
For what to come inside?
Glucose.
Glucose. It opens the door so that glucose can enter the cell, right?
Right.
Yes.
But anytime you open the door, remember potassium's a homebody, and there is potassium in your blood too. Y'all know that, right? I mean, obviously.
Yes.
Yeah, okay. So as soon as insulin opens the door, that potassium, like, whoosh, it's going to go home. As soon as the door to their home is open, it will always want to go home. Okay.
Okay.
All right. So that's how insulin and potassium go on a seesaw. Okay. So picture this. If my insulin level is high, then my blood, because when you draw potassium levels, that's in your blood, right? So as soon as insulin opens all these doors, to all these cells, who's going in them? Potassium. So it'll rush into the cell, which leaves very little in the blood. That's how they go on a seesaw. Do you understand that?
Yes.
Do you understand that?
Yeah.
If you don't, you need to say, I don't understand it.
Yeah. I think so.
I get it.
Thank you. Okay. All right. So these will go to, we got this. Yes.
Yes.
Okay. So like in the case where you have type 1 diabetes and they have no insulin, then what's going on in these cells?
It's not open.
All the doors are closed. So the potassium has to stay in the blood because it can't get in there. You see what I mean?
Yes.
Okay. All right. So increased insulin would cause hypokalemia, yeah? Because all of the potassium went where? Where'd he go? He has gone home. Yes. Right? Increase insulin. Okay, you got me. All right. Why would diuretics cause hypokalemia?
Because your kidneys are.
You're overriding your kidneys, right? So diuretics are going to force your kidneys to get rid of things they normally wouldn't get rid of. And we got those 3 electrolytes, right? That are in that the kidneys. Okay, you got this. Okay. DKA. Now I can't go into huge detail with this because we'll do this in diabetes, but do you know what DKA is?
Diabetic.
Diabetic ketoacidosis. And do y'all know what it is?
Something about
Excuse me.
I don't know
It's,
exactly what it is.
What's low?
Your
Okay.
It's like they say
No,
if you
y'all.
have acidosis, then you're sitting on your ass.
Oh no, what that's something different. That's saying anytime a patient has diarrhea, so something is coming out your ass, anything if it's coming out your ass, you're in acidosis.
Yeah.
So like if a patient has severe diarrhea, they'll be in metabolic acidosis. But what does this have to do with your butt?
But I was thinking acidosis, like I was thinking.
Oh, I see.
Would it be the chloride is high in your kidneys?
No, what is DKA though? Diabetic.
It's type 1 diabetes. Like when you can't produce any insulin.
Oh, that's terrible. Okay, so that's a good start. Okay. Okay, so we'll just come back to it. Okay, because DKA, oh, actually, homework sheet. I have an entire hour video on DKA because that is totally out of the scope of today's class. But if you're really interested in it, which you're gonna have to know it eventually anyway. Okay. You can go watch that video. Okay. which we'll cover another time. All right, NG suction. So this is like when you put in an NG tube and you're sucking out whatever's in their stomach, an NG tube to suction.
Right.
Why would that cause hypokalemia?
Clean it out.
Potassium in the stomach.
Yeah, because potassium is a predominant electrolyte in the
Gut.
stomach. So if it's suctioning out all of that potassium, you're going to get hypokalemia. Yeah. Signs and symptoms of hypokalemia. Which keyword? Okay, so arrhythmias, dysrhythmias, any of those words are, no. Y'all know arrhythmia and dysrhythmia are basically the same thing.
Yes.
Nobody ever told me that. Okay, so I was like, on the EKG, how do we know what their potassium's doing?
T-wave.
T wave. So the T wave tells us what the potassium's doing. So if it's hypokalemia, then you're going to have a inverted T wave. Got it? Okay. So if potassium makes action potentials, right, and it makes your heart beat and you don't have any potassium, then cardiac arrest.
Oh,
Yeah. Yes, your heart can just stop. Okay. And then you got to think, if potassium's job is to make action potentials all over your body, right? And it's not doing that anymore. So you don't have any like electrical activity throughout your body. Yes. So how are they going to feel? Lethargic, and their muscles are going to feel weak. What's their gut going to do? Stop. So constipation. They can get an ileus. What's an ileus? Well, it could be from a block, but an ileus means that your gut is frozen. It's not moving at all. That's very bad. Damn. I mean, you can die from it. It's very serious. Okay. All right. So how do I fix hypokalemia? Give them potassium. Okay. So if it's mild decrease, like let's say their potassium is 3.3, and you'll know like any change in potassium is like a big deal though, right? But let's just say it's like 3.3 or 3.4. What route would you give it? That's mild, right?
Yeah.
So we could just get a PO. They can get a PO potassium supplement every day, right? What if it is 2.8? Yeah, we can give it IV. Now, potassium IV hurts like all holy hell, and you have to be very careful. You have to give it very slowly or else what? Yo, what is your keyword for potassium? Heart. Okay, so if you're giving a shit ton of action potential, your heart's going to... Your heart will explode. You can actually end up getting cardiac arrest too, because it's going to go so fast, it's just going to stop going. Do you understand what I'm saying? So when you give IV potassium, that's very dangerous. Okay. You have to give it super, super, super slow. Can you give it IV push?
No.
That is called death. That is how they kill prisoners. Do we understand? Mhm. Okay. Oh, this is a very big deal. And I wrote this all down for you, y'all know, but if you want to write it down, that's fine. Remember how I told you that if it's more than D10 or above, that you need to give it their essential line. Well, slowly, that's fine too, but their essential line, right? For potassium, there's a rule as well. You cannot give more than 10 MEQs per hour, because you know potassium comes dosed in MEQs, milliequivalents. Okay. But most of the IV bags come with 40 milliequivalents. So you need to calculate your hourly rate and make sure that they're not like going to kill a patient today because they're getting too much too quickly. So for instance, like the normal bag may come with 1,000 mLs. That's like a liter bolus, right? I mean, you can't bolus potassium, so that's not what I meant. The bags usually come as a 1 liter. You'll know that. So let's say I go to the Omnicell and I grab this 1,000 ml bag. That's a standard IV bag. So it's 1,000 mLs of normal saline plus 40 MEQs of K. That's pretty normal. Okay. And the doctor orders 260 mLs an hour. Are y'all just going to sit here and stare at me, or what do we, you're going to have to try to maybe calculate it or something. Sure. So you have 1,000 mLs, normal saline. Okay. There's 40 MEQs of potassium in the bag. Okay. And the doctor orders it to be given at 260 mLs per hour. Correct. If that's safe or not safe.
And you said that you can't do more than 10.
You can't do more than 10 MEQs per hour.
It's like, right, it's borderline.
So it's not safe.
But it's over still, right?
Yeah.
So you would call the physician and say,
It's not
we're
safe.
not going to kill a man today.
Right.
Do you understand how to practically apply this?
Yes.
Okay. All right. And that's something you always have to check because the doctors may not do that.
Okay.
And it is never, ever, ever your job to add potassium to a bag. That's very dangerous and that should never be given to you. It should come up mixed already. Okay. All right. Where was I? Oh, IV no more than 10 MEQs. Oh, okay. Oh no, I already said that. All right. So, do we understand hypokalemia?
Yes.
All right. Hyperkalemia. What would cause hyperkalemia?
Too much potassium.
How? That's what it is, but how, what causes? Well, like you ate too much of it. Well, you did a banana diet for 10 days. I mean, it's a possibility.
You have type 1.
Yes.
Okay, so. So is it like they're getting too much insulin that keeps opening up the wound?
No, that would be hypo, right?
Okay, so they're not getting anything.
Because remember, they go on a seesaw, right? So if they were just being diagnosed with type 1 and they had no insulin, right, they may at least start with hyperkalemia. But the treatment for DKA, we put them on massive loads of insulin as soon as they come in IV, right? So that patient's going to end up getting hypokalemic, right? But when they first go in before they've gotten any treatment, yeah, if there's no insulin, then absolutely. So yeah, we could say that for sure. Yeah.
Yes.
Cool. Okay. What organ is responsible for getting rid of
CHF.
potassium? The reason why CHF doesn't cause hyperkalemia is because it's not going to mess with their potassium in any kind of way.
It's kidney failure, right?
Kidney failure. Kidney failure, because what is kidney's job is to get rid of potassium. And if that has failed,
Yeah.
it is not getting rid of potassium. Yes?
Yes.
Okay. And then y'all know there's a thing called potassium sparing diuretics, right? Because most diuretics make you waste potassium, like you get rid of all your potassium, but there are some that make you not do that. Okay. And they're called potassium sparing diuretics. And the name, the most common one that you'll see is called spironolactone, right? Potassium. I don't know how to spell it. Okay. Okay. Yeah, whatever. Anyhow, spironolactone is potassium sparing diuretic. Okay, which we'll talk about that another time. That's kind of out of the scope of here. But potassium sparing diuretics, ACE inhibitors will also cause hyperkalemia. Do you know what ACE inhibitors end in? What's their ending? ACE inhibitor drugs end in pril. Have you ever heard of like lisinopril or yeah? Okay. All right, then. Okay. Okay. Why would ACE inhibitors cause hyperkalemia? What is ACE? Angiotensin what? Okay, so if it's an ACE inhibitor, then it inhibits the enzyme. It's not converting to angiotensin 2. And we had 2 cascades for angiotensin 2, right? Aldosterone, which holds in
Water.
Oh, sorry.
sodium and water, and ADH, which holds in water. Okay, so most of the time when you've got the RAS system, it's going to hold in salt, right? But if you're blocking the end result, where's your salt going? Out. It goes out, right? Do you understand what I'm saying? The RAS system holds fluid in. If I'm blocking the end of the RAS system, then the salt and water is going to go out of your body. You're going to pee it out. So if you're peeing out all your salts, right? Sodium and potassium go on a. So if your salt goes down, your potassium goes up. That's how potassium sparing diuretics work. And that's how ACE inhibitors work. Do you understand what I'm saying?
Yes.
Okay. All right. Where were we? Renal failure. I did all these. Okay. So signs and symptoms of hyperkalemia. What's your keyword for potassium? Heart. So dysrhythmias, arrhythmias. What's going to happen to your T wave?
It's going to be
It's going to peak. They can go into full out cardiac arrest, right? Because you're like, yes.
Yes.
Okay. And they're going to have nausea, vomiting, because your body's trying to get rid of that potassium that normally lives in the stomach. And we know that potassium makes action potentials, right? So all over your body, you're going to have cramps and twitches and spasms. Yes.
Yes.
Paresthesias, which mean
Tingling.
tingling, right? And anxiety because everything's firing off like really fast. And you're like, yeah, stop it. You understand?
Yes.
How do we fix it? This is one of the most vital things I could ever teach you.
Give salt.
Get a piece of paper out. Okay. All right, blank piece of paper. Here we go. All right, I want you to give me your potassium sea salts and where they're located.
Yeah, one in the kidneys.
All right, what potassium goes with what?
Sodium.
Sodium. Okay, there's one in the heart where potassium goes with
Calcium.
calcium. And then there's one by the cells that we just talked about, and that is,
By the cell.
yeah, opens the door.
Oh,
Insulin.
Insulin. Okay. So when you're looking at antidotes for hyperkalemia, because hyperkalemia, extremely dangerous, dysrhythmias, cardiac arrest. Oh my God. Yeah. What's the first thing you do when you think your patient has a potassium problem? Y'all, what's your keyword for potassium? So what's the first thing you want to do?
EKG.
EKG. What's the first thing you do when you think your patient has a potassium problem? EKG. You understand?
Yes.
Okay. So when I'm looking at antidotes for hyperkalemia, very dangerous, right? Life-threatening dysrhythmias, like they could just totally just code out on you. Yes, that's not even a word. They could code on you. Okay. So when I'm looking for antidotes for hyperkalemia, there are 6. This is so important. It is in every nursing school, in every class, and NCLEX, ATI, HESI, they love this. You've got to know this, okay? But you need to understand why and not just memorize them. Okay, so antidote number 1 for hyperkalemia,
Calcium.
okay? Calcium gluconate is the type of calcium, okay? Antidote number 2, sodium bicarb. Antidote number 3,
Insulin.
insulin. Now, what happens if my patient is non-diabetic? What happens if they're not diabetic and I give them a shit ton of insulin to fix their potassium problem?
You have to give it with.
You're gonna bottom them out, right? With blood sugar. Their blood sugar's gonna be like 2, and you're like, I'm sorry. Okay, so we should also give them sugar so that they don't get hypoglycemia. What's the highest form of sugar you can give somebody?
50.
Yeah. So if they're not diabetic, I would give them insulin plus D50 so I don't kill them with their hyperglycemia. You understand that?
Yes.
If they are diabetic, the insulin will probably do some good. Yeah?
Yeah.
Do you understand why these sea salts are so very important? Okay. So if nothing in your body is working and everything fails and we just take out all your blood, clean it out, clean all the potassium out and give it back to you. What's that called? Dialysis. Okay. There is an actual antidote for hyperkalemia. Okay. I cannot tell you how important it is that you know this. There is no nursing school on any exam that I've not seen this covered. They love the crap out of this. Now the brand name is called K-Exolate, which, oh, that'd be so easy to remember because it has a K in it, right? Like potassium, yes.
Mhm.
But they're not going to say K-Exolate on an exam because that's a brand name. They're going to say it's generic name.
Oh.
Yeah, I cannot tell you how important this is. I made them because they kept forgetting it in farm. I made them write it 10 times on their paper like we were in Catholic school. So it is called sodium polystyrene sulfonate. Oh my God. Which you probably would be able to get it on an exam anyway because it has,
Sodium.
yeah. But you'll have to know this. It's coming back to get you in 2nd semester, and you'll see it again in 3rd semester, and you'll see it again in 4th semester, and you'll see it again every day you go out onto the unit. Okay. Sodium polystyrene sulfonate. Now, how does your body normally get rid of potassium? I've asked you this question about 100 times today, huh? You pee it out. When that is broken for whatever reason, obviously it's not working because you have high potassium. Okay, your body's got to get rid of it another way. How would your body get rid of it if your pee won't get rid of it? Your poop, right, your poop. What does sodium polystyrene sulfonate make you do? Shit, yes, lots of times. How do I know it's working?
If you're pooping.
They're pooping 3 to 4 times a day. I want them to poop out all of their potassium. You understand? Okay. And then the last one, this one's actually kind of fun if y'all want to play with it. Let me see how much time we got. Shit. Well, I don't have a lot of time to spend on this, but I'll see if we can have fun. Do you know what albuterol is? Huh? Yeah, it's a what? Broncho dilator. Okay, so how the hell would that help with my potassium?
Because it's causing vasodilation or something.
Isn't it high?
What's the question?
What is albuterol? Like, how does it work? What's its job? You also do use it for asthma, so.
It opens the airway.
All right, it is a bronchodilator. How does it work though? And what kind of response of your body do you bronchodilate?
Anna.
What part of your body?
No, like what-
Reaction.
No, that closes it.
Oh.
Yes.
Oh.
Doesn't your fight or flight response make you bronchodilate? When you give albuterol, it is a fight or flight response. That's what in the medicine is, a fight or flight response.
That's what makes you
Okay.
jittery.
Yes. So albuterol is a fight or flight response. What hormones are coming out? Y'all better be careful. What hormones come out? Yes, epinephrine and norepinephrine, right?
Mhm.
Okay, what happens to your blood sugar in a fight or flight response?
Goes up.
It goes up. As soon as your blood sugar goes up, how does your body respond? What does it produce?
HP. Sorry.
What?
When. Oh, I thought you used glucose for energy. So that's why
Oh,
said
I thought you said HP.
Oh no.
Like Hewlett Packard or something? I was like,
HP.
oh, I see what you're saying. Okay, so hold on. So let's just make sure that all right. Your fight or flight response, albuterol is a fight or flight response, right? So you produce epinephrine, right? Epinephrine makes your blood sugar go up. As soon as your blood sugar goes up, how does your body counteract your high blood sugar?
Insulin.
Thank you. So your body is going to increase its insulin, right? This is natural. This is how your body works. Yes.
Yes.
Okay. So in a massive fight or flight response, your blood sugar is going up, then your insulin goes up, which means your potassium's gonna come down. Okay. You understand that? This is so serious. Okay. Do you understand the 6 antidotes of hyperkalemia? You will see this a million times in nursing school. Okay. All right. We're going to move a little bit faster. Okay. All right. Calcium, normal levels. All right. So 8.5 to 10.5. Okay. What's its keyword?
Muscle.
Muscle. Yeah.
A little bit of heart.
With a little bit of heart. Yeah. So what's calcium's job?
Muscle contraction.
It does help with muscle contraction. It's the main component in your teeth and your bones. Hello, everybody. Calcium plays a big role in blood clotting. You might not have known that. I don't know if you did. And it helps your hormones communicate. Okay. So what would cause hypocalcemia? Y'all start with the easy ones. You didn't eat any. Calcium is the only electrolyte that you have to eat. Your body does not make calcium. You have to eat it. Okay. So what are patients that would not eat calcium? Maybe they're allergic to dairy. Maybe they're vegans. Don't eat the dairy. You know what I mean? Okay. All right. So just start with easy things. Yes.
Yes.
Okay. What has to marry with calcium in order for calcium to be absorbed? Vitamin D. So if you don't eat enough vitamin D, or you don't take in or take a supplement or whatever, vitamin D, you can't absorb calcium. So your calcium would be low. Yes. Okay. Whose job is it to balance calcium? But what organ? Sorry, what organ? The parathyroid, right? And didn't we already do hypo and hyperparathyroidism? Okay. So which one causes low calcium? Hypoparathyroidism. Because what's the parathyroid's job? Parathyroid hormone's job? Pull calcium out of the bone and put it into the blood. So if that's not happening, then you don't have any calcium in your blood. Yeah. Okay. So hypoparathyroidism would be a cause. You're just going to have to know this for now because we have not covered GI, that pancreatitis causes hypocalcemia. It's a big testable point. You definitely 100% need to know it. We just don't have time to go into all the details today. What goes on a seesaw with calcium in the parathyroid? Phosphorus. Okay. So what's a cause of hypocalcemia? Hyperphosphatemia. Hyperphosphatemia. All right. And then even though calcium is not the main, a main electrolyte the kidney gets rid of, it does help if it goes too high. So if you're in kidney failure, eventually you're probably going to get hypocalcemia. Okay. And we'll talk about that at renal. Okay. All right, signs and symptoms. So what you need to remember is calcium in and of itself is lazy. Okay, so hypocalcemia, it's less lazy. So all your muscles are tight, tense. So tetany and spasms. And what's chavosis? You flick the cheek and like, mer, 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 mer. What's trousseaux? Blood pressure cuff. You pump it up really tight for 2 minutes and your hand's gonna, it's gonna spasm into a sign language T for trousseaux. That's not why they did that. I just made that up. All right, your abdomen is gonna be like cramping because you've got like, you know, everything is tight. Yes? Huh? No, because it's not moving, it's cramped.
Oh, okay.
Right? Paresthesias, right? So a lot of patients, as soon as they get hypokalemia, they'll say like, I can't feel my hands. You're like, oh no, let's check your calcium. Okay. And then since it's a little bit of heart, arrhythmias. Okay. How do we fix it? Give them calcium. If it's mild, we're going to give them PO. If it's severe, we give them IV. It burns like potassium, so you got to give it really slow. Okay. What else can I increase to increase their calcium? Vitamin D. So we're going to tell them to increase their vitamin D. What can I decrease to increase their calcium? Phosphorus. So I'm going to give them what's called phosphate binders. It's drugs that you can give to decrease your phosphorus, which hopefully will increase your calcium. Very good. Do you understand that? Okay. Hyperkalemia causes. Think simple. You took too much in. Okay, that's fine. Or you took way too much of vitamin D. Yeah. Or you have what type of parathyroidism? Hyperparathyroidism. Okay. Or your phosphorus is very low. Oh, this is so easy now. Okay. Okay. Signs and symptoms. Since calcium in and of itself is lazy and now it's hyper, it's like, so they're going to be like very tired. Their muscles are going to be weak. Is their gut going to move? No. So they're going to be very constipated. They've got myalgia. What's myalgia? The muscles are like sore and they're tired. Okay. And then because we have all of the calcium is in the blood and not in the bone, then you're going to get fractures, which osteoporosis, right? And your kidneys are going to be like, I don't normally do this, but I will help you in this case. So I'm going to try to get rid of this calcium for you. No, that's not normally my job, right? So you'll get polyuria, right? Because it's going to be like, I'll help you, but I'm going to have to like try to peel on it. Okay. You understand? Okay. And then because it's a little bit of heart, arrhythmias. Yeah, just arrhythmias. Okay. And what does, if you have excess calcium, it likes to bind up together to get rid of itself. Kidney stones. We understand?
Yes.
Okay. How do I treat high calcium? Well, you can't give phosphorus. There's no way to do it. Calcitonin, because it tones down your calcium. It's a drug. Okay. You can give calcitonin because it tones down your calcium. Now, if your kidneys are willing to help, can I just give them some IV fluids to kind of let their kidneys help get rid of the excess? Can I give them some diuretics to help move the process along? Yeah. Okay. And then there's a drug class called biphosphonates. That is the osteoporosis drug class. They all end in dronate. Okay. So we're helping to like build healthy bones until we can fix the problem. Okay. If all else fails and I'm like, I can't fix this, I'm gonna have to pull out all your blood, clean all the calcium out of it and give it back to you. Dialysis. Do we understand?
Yes.
All right. Last one, magnesium. What's normal magnesium level? 1.5 to 2.5. What's magnesium? What is it? It's a muscle relaxer. Yeah.
Yes.
Okay. So what is important to note about magnesium? Even though magnesium and calcium go on a seesaw in the muscle, okay, the signs and symptoms are the same. Hypocalcemia, hypomagnesemia, hyper. Okay, so it makes sense so much easier. Okay, I'll show you what I mean. So low magnesium, pretty much everybody in America has low magnesium because we don't eat enough of it and they don't talk about it enough. Okay, so and you have to intake. Your body does make some mag, but you do have to intake a lot of it and we just don't do it. So pretty much everybody does. So low intake is one of them. If they have chronic diarrhea, because magnesium is absorbed in the gut, right? Because you eat the magnesium, it goes into your gut and your body absorbs it. But if you constantly got like diarrhea running through there, you can't absorb any of the magnesium. Do you understand that?
Yes.
IBS, what's IBS? So inflammatory bowel, yeah. Or irritable bowel syndrome, I think is what y'all are talking about too. So that's gut issues. Okay. Any major gut issues for a long period of time, you're not going to absorb your mag. Do you understand? Ulcerative colitis, same thing. Laxative abuse. Y'all see like, it's all the same thing. It's your dookie. Yes. Okay. Hypercalcemia would cause hypomagnesemia. Yes. Okay. Or prolonged fasting because you didn't eat any. Those are very easy. Yeah. Okay. Signs and symptoms of hypomagnesemia. So twitches and tetany and spasms, yes? But this can be actually pretty bad, to the point where you can get seizures, hypertension, because even your vessels are clamped and you can feel a lot of severe anxiety. Your DTRs are going to be increased. What are your DTRs? Yeah, so when you go and you do the little hammer and you go like this, they're going to go whoop like that. Okay, so watch out when you do those. You understand? Okay, so how do I fix hypomagnesemia? Give them mag. Yeah, this is very easy. Yes. PO, IV, depending on how severe. Okay. All right. So let's talk about causes of hypermagnesemia. This never happens, by the way. I mean, usually it's because you have the patient on IV mag. It's very hard to get so much magnesium where your body's like, I'm toxic. Okay. The only time is that, but like moms that we're trying to prevent going into labor, we put them on IV mag. Because what is mama magnesium? It's a muscle relaxer. So when mom's like, you know, contracting and going into labor, we give her IV mag to relax the uterus that she'll stop going into labor. Does that make sense?
Yes.
Okay. Now, even though mag is not one of the big electrolytes secreted by the kidneys are very quick to help if you have too much mag. Okay. So if the patient goes into full renal failure, they may end up getting a buildup of magnesium. Okay. Magnesium antacid overuse. So these are patients that have GERD. That I didn't mean to do that. That really coincidentally happened. But you know, like there's tons of magnesium antacid. So people are like popping antacids all day, every day, can go into hypermagnesemia. That better not be you. Okay. So what are the signs and symptoms of hypermagnesemia? Same as so explain them to me. Like weakness, fatigue, lethargy. Okay, but there's an acronym for mag because this one is more severe than calcium and it's called BURP. So see if y'all can figure it out. If everything is like super slow down, B would stand for bradycardia. U, urine output is decreased because it's like burp. R, respiratory rate is decreased. And then P, y'all will never get because it's rude. Patellar reflexes are decreased. Patellar, remember like that, whoop, whoop, right? So those are going to be decreased, right? So everything, they're going to get hypotension, like hyper mag can be very dangerous if you do actually get it. It's just not common in the public because there's no way we could eat that much. This would be that you're actually giving something. Okay, but what I do need you to be careful with, the only difference between hypercalcemia as far as signs and symptoms, hypercalcemia and hypermag. If you notice in hypercalcemia, they get polyuria, right? Because your body's trying to get rid of it. And hypermag, because it's a muscle relaxer, your bladder won't even contract to pee. So they would have decreased urine output. Those are the only two that are opposite. Everything else is pretty much the same. Does that make sense? Okay, so how do we get rid of their mag? Make them pee it out so we can give them diuretics. Okay, what else you want to do? What goes on a seesaw? Okay, so you want to give them some, yeah. And then if all else fails, we have to pull it all out. Okay, easier now?
Yes, thank